Welcome everyone to the fourth season of Journal Club meeting hosted by Maharashtra Ophthalmic Society and jointly with Bombay Ophthalmic Association. I welcome you all to this fourth season. And today it's a big pleasure to invite. We have stalwarts, and uh, it'll be a great talk and a great treat to hear them. And we have Dr. Haldipurkar sir, who is a veteran, and he's the medical director, Lakshmi Eye Institute, Navi Mumbai, and he needs not more any introduction. We have Dr. Haripriya, madam, who's the chief IOL cataract services, Arvind Eye Hospital, Chennai, and Dr. Sel Vasavda, consultant cataract and IOL, Raghudeep Eye Hospital, Ahmedabad. So, without much further ado, I ask the incoming Maharashtra Ophthalmic Society president to open the talk and open the event.
Okay, thank you, Dr. Vaishal.
Yeah.
Good evening, all. First of all, let me thank and congratulate Dr. Vaishal and team MOS for arranging 3 seasons very successfully and making this meeting a very great success. And this is the first meeting of 4 seasons, and I'm sure that it will be a great academic and scientific feast for everyone. I really thank Dr. Lane sir, Dr. Haldipurkar sir, Dr. Shail Vasala, and Haripriya ma'am for sparing their valuable times. On behalf of MOS, I'm really thankful to everyone.
Thank you for those kind words. And I now ask the BOA president to give his opening remarks. Dr. Nitin Balkrishnan. Yeah.
Thank you, Vaishal.
Yeah.
On behalf of the Bombay Ophthalmological Association, it is my pleasure to welcome all of you all to today's Journal Club meeting. As you know, we have had 3 seasons of the Journal Club meeting, and kudos to Vaishal, Dr. Parul Deshpande, and the entire team of the Journal Club of BOA and MOS. So this is a platform where we can exchange insights about the latest, what is happening in the field of ever-evolving field of ophthalmology. So today's article is a very interesting article on triamcinolone as a standalone inflammation prophylaxis after cataract surgery. And it really would help us to know whether this sort of treatment could simplify postoperative care for both our patients and for the doctors themselves, while maintaining a proper inflammation control by preventing the frequent need of using steroid eye drops. So I take this opportunity to invite Dr. Haripriya.
Prospective comparative effectiveness cohort study, and it included all patients undergoing simple and complex adult phacoemulsification cataract surgeries performed in the Kaiser Permanente Northern California group of hospitals from 2018 to 2021. And the patients with at least 12 months of KPNC enrollment before the surgery date were included, and only the first cataract surgery of these patients was included in the study. Exclusion criteria included all patients who were operated by surgeons with less than 50 cataract surgery experience, patients with a prior history of cystoid, diabetic, or clinically significant macular edema, iritis, uveitis, and endophthalmitis. Any patient who did not have a defined exposure to TA or PA in terms of the dosage information noted in the electronic health records, and patients who had exposure to both the injection TA and topical NSAIDs were excluded. Taking into consideration all these criteria, the final study cohort was found out to be 69,832. For this final study cohort, data collection was done from the electronic health records, which included the demographic information, that is the age and sex at the time of surgery, self-reported race and ethnicity, body mass index, history of diabetes and smoking recorded up to 2 years before the surgery, and the median household income group. Also, ocular comorbidities like ERM, retinal venous occlusions, diabetic retinopathy, and glaucoma were noted. The postoperative prophylaxis that the patients received was noted in the form of the drug given, the concentration, and the dose at which it was given. This final study cohort was further divided into 6 exposure groups, which included the injection TA groups and the topical PA groups. The injection TA groups was further divided into 4 groups, which were the TA low concentration low dose group, low concentration high dose group, high concentration low dose group, and high concentration high dose group, where low concentration was defined as 10 milligram per ml and high concentration was defined as 40 milligram per ml, while the low dose was defined as 1 to 3 milligram and high dose was defined as 3.1 to 5 milligrams. The topical groups were the topical prednisolone acetate alone and topical prednisolone acetate in combination with a topical NSAID, including either diclofenac sodium 0.1% or ketorolac tromethamine 0.5%. The patient outcomes were studied in the form of prophylaxis effectiveness and safety, where the prophylaxis effectiveness was studied in the form of macular edema and iritis, where the first diagnosis was to be recorded between 15 to 120 days after cataract surgery in the index eye, and the second up to 365 days after the first diagnosis. The safety was studied in the form of a glaucoma-related event, where the first instance of an IOP of 30 millimeter of mercury or more, or 10 millimeter of mercury or more over the baseline, recorded between 15 days to 1 year after the surgery. Any patients who had a new field prescription for an AGM between 15 days to 1 after the surgery without a history of glaucoma, and any patient who underwent new glaucoma laser procedures or surgical procedures in the index eye within 1 year were studied. Statistical analysis was done with the SAS version 9.4 software by the SAS Institute. The clinical and demographic baseline characteristics were summarized using the means and proportions and were tested for statistical significance using the chi-square test. The conditions that may influence effectiveness or safety outcomes in the study, that is ERM, RVO, DR, and any other retinal diagnosis of macular edema or preoperative glaucoma-related diagnosis, were included in the relevant multivariable model. In the main model, the results were as follows. For the topical prednisolone group, the incidence of macular edema, iritis, and postoperative glaucoma-related events was 1.3%, 0.8%, and 3.4% respectively, while in the injection TA group, these occurred at the rate of 0.8%, 0.5%, and 2.8% respectively. The rate of IOP elevation in the TA 40 milligram per ml high dose group was the highest, and in the TA 10 milligram per ml high dose group showed similar percentage of IOP elevation when compared with the prednisolone acetate group in this model. Followed by which the bivariate analysis was done, which examined the association between the socio-demographic characteristics and macular edema, iritis, and glaucoma. In this, it was found out that the rate of postoperative inflammation was higher in Black and Latina males and in patients with diabetes and eyes with diabetic retinopathy, ERM, and retinal venous occlusions. Glaucoma-related events occurred at a higher rate in non-whites, males, and patients with preoperative history of glaucoma-related diagnosis. The patient body mass index, smoking history, and medium income category were not associated consistently with any statistical outcomes. Followed by this, a multivariate regression analysis was done, in which there was done clustering for surgeon and medical center and adjusting for race, sex, age, year of surgery, diabetes, ERM, RVO, DR, and any other retinal problem was done. In this, it was found that when compared with the topical PA cohort, in the injection TA cohort, including all concentrations and doses, there were lower odds of macular edema and similar odds of iritis and glaucoma-related events. On analyzing the odds of postoperative macular edema, the TA 10 milligram per ml high dose group had a lower odds when compared to topical PA group. Other injection groups also demonstrated lower trends of lower odds, but did not reach a statistical significance. There were higher odds of post-op macular edema in Black or Latina males and patients with previous diagnosis of DR. A modified analysis was done by excluding patients with a preoperative diagnosis of ERM, RVO, or DR, and it was found that the TA 10 milligram per ml high dose group had lower odds of macular edema when compared with the topical PA with or without NSAIDs. On analyzing the odds for postoperative iritis, taking into consideration that the two instances of diagnosis had to be noted, there were lower odds in the TA 40 milligram per ml injection groups. However, none of the treatment groups showed a statistical significance. After this, which a modified analysis was done, in which only a single instance of postoperative iritis diagnosis was considered, and it was found out that the TA 40 milligram per ml low dose and high dose group had lower odds of post-op iritis than the topical PA group, and this reached a statistical significance. On analyzing the odds for postoperative glaucoma-related events, it was found that the TA 10 milligram per ml groups, both low dose and high dose, had lower odds of glaucoma, and TA 40 milligram per ml groups, both low dose and high dose, had higher odds of post-op glaucoma when compared with the topical groups. And the post-op glaucoma had higher rate in Blacks, Asians, males, and patients with preoperative glaucoma diagnosis. Coming to the discussion part, previous studies have noted that on giving injection TA 20 to 40 milligrams sub-Tenon dose, when compared with topical corticosteroid, had or lower odds of postoperative inflammation, while injection TA 2 to 5 milligrams subconjunctival dose had similar or lower odds of postoperative elevated IOP on comparison with the topical corticosteroids. Also, on comparison with these topical corticosteroids, injection TA 12 to 20 milligram and 40 milligram subconjunctival groups had higher rate of elevated IOP. As, as seen previously, the 2 milligram injection TA 40 milligram per ml dose, the depot was visible for 8 to 12 weeks post-operatively. So in this current study, we have noted that the 4 milligram of TA, 10 milligram per ml subconjunctival depot was visible for 6 to 8 weeks, and when compared with the topical groups, it had lower odds of postoperative macular edema and similar odds of postoperative glaucoma. We know that the subconjunctival depot is eliminated through scleral diffusion, conjunctival lymphatics, and the blood vessels. So it can be concluded that the larger volume, less concentration TA 10 milligram per ml, as it covers a larger surface of area, it will have a faster dissipation when compared with the same dose of TA 40 milligram per ml, which has a smaller and a denser depot. And as risk of IOP increase may be related to the duration of steroid exposure, it could have a lower odds of postoperative glaucoma related events. On studying the location of the injection, it has previously been noted that the injection TA, when given closer to the limbus, will have a higher concentration of steroid detected in the anterior chamber, which will result in higher mean IOP elevation. Therefore, in this study, the injection was given at 6 to 8 millimeter inferior to inferior limbus, as it balances the postoperative inflammation prevention and IOP elevation. Also, it obscures the depot to the patient. Subconjunctival injection was preferred over subtenous injection, as the needle tip can be visualized during the injection and also minimizes trauma or scleral perforation. Also, subconjunctival steroid depot is visualized more easily and can be monitored as it dissolves over time. In this study, there was an instance in which a superior injection was given, where the depot had an apparent migration inferiorly, which could be because of gravity while the patient was in sitting or standing position. So we can conclude that their odds of increased risk of postoperative IOP could be seen when there is a presence of visible subconjunctival depot. So for this, if needed, excision of the steroid depot can be done, which will result in the elevated IOP returning to baseline within 1 day to 1 week. Also, the odds are higher in patients with a previous history of glaucoma and in patients with 50 years or younger and with higher myopia and longer axial length. So we can avoid giving long-term steroid depot injection in these patients. So in conclusion, injection of TA 10 milligram per ml 4 milligram dose in the subconjunctival space 6 to 8 mm inferior to the inferior limbus at the conclusion of phacoemulsification cataract surgery was associated with lower odds of diagnosis of postoperative macular edema and similar odds of glaucoma-related events when compared with the topical PA with or without NSAIDs. While the highest strength drug, that is the TA 40 milligram per ml, was associated with lower odds of postoperative macular edema and iritis, but showed statistically higher odds of postoperative glaucoma-related event in the lower dose and higher dose groups. This will potentially limit the value of this formulation in the routine cataract surgery. And the patient should be monitored in the postoperative period for IOP elevation and dissolution of the steroid depot. And caution should be exercised in patients with preoperative glaucoma diagnosis, optic nerve compromise, and patients with high myopia and relatively young patients. So what are the strengths of these studies? One of them could be that this study had a large diverse study population. The authors, the variation in the approach, there was variation in the approach to prophylaxis given, and the authors had access to comprehensive data, including the diagnostic information and also the drug administration. The authors excluded eyes with high risk for postoperative macular edema to avoid confounding due to prescription of topical NSAIDs by surgeons for these patients. Also, they excluded eyes that received an injection plus an NSAID and thus avoided confounding factors. The limitations would be that it was a non-intervention design to randomize patients to the injection groups and topical groups. It is possible that some patients experienced an IOP rise beyond the 1 month routine visit, which could have been missed. Also, OCT macula was not performed in all patients and only in patients with suspected macular edema. So there are chances that they could have missed any cases of subclinical macular edema. A trend of lower odds of macular edema was seen in the TA10 40 milligram per ml injection groups that did not reach statistical significance. This could be because of the limited sample size. Also, we could not ascertain the precise location of injection, including distance from the limbus for each patient, as it was not noted for each patient. The study did not consider use of postoperative antibiotics and lubricating drops. Coming to the MARI framework, this study design was a retrospective comparative effectiveness cohort study. A better study approach could have been a randomized control trial. The study hypothesis was well defined. The study population, the inclusion and exclusion criteria were also well defined. The sample size was appropriate. The assignment process of allotting the participants to groups based on medication and dosage information obtained from the electronic health records was matched for the parameters to be studied, and it was appropriate. The assessment was done based on the measurement of the based on the prophylaxis effectiveness and safety measured by the macular edema and glaucoma related events respectively, and it was appropriate. The accuracy of assessment, as the postoperative macular edema and iritis had to have at least 2 diagnostic codes, was well defined, while operative glaucoma related events were well defined and documented. But the follow-ups were not well defined and uniform in the study. The p-values showed significance in the patients with macular edema and the glaucoma-related events group, but did not reach a statistical significance in the iritis group. The statistical techniques were appropriate, and the adjustments done for confounding variables were appropriate. The interpretation of the study that the 4 milligram TA 10 milligram per ml subconjunctival injection in combination with intracameral antibiotic injection may offer prophylaxis therapy that avoids patient adherence issues was appropriate. The study included patients operated at the KPNC, California, and there was a huge racial diversity in the study, but the authors have not extrapolated the data beyond the study population. These are my references. Thank you.
Thank you, Girija, for a wonderful presentation. Now, we would just ask our statistical expert, Dr. Sabyasachi Sengupta, to give his comments on the article. As he wants to leave early, we would be taking him immediately after the article. So, Dr. Sengupta, are you around?
Yes.
Yeah, can you?
Thank you so much, Parul, for giving me the chance to jump above everyone else. I'll just quickly share my screen and show you what annotations I have done on this paper. So it's a very large study, isn't it? I mean, like 70,000 patients. And so, intuitively, quickly, we'll think that, oh, this is something that we should be taking to clinics, and this is something that we should be applying to clinics. But then, there are certain issues which we should discuss. When just looking at the abstract, first and foremost, the number of groups are not really clear from this intervention section, where they say exposure groups included topical PA with or without NSAID and topical subconjunctival injection of Canalog. And then there are 2 doses, and then again there are low dose and 2 concentrations and lower and high dose. So most likely there are 6 groups, but still it's not very clear. How they define macular edema for this study is not well defined. Later on, they say they use the ICD-10 coding, which is actually H59. But when you look at it, and I tried to dig in, including the supplementary material, it's not really there. So, it just says if the physician sees CME, they will report it as CME. But then, it's not a uniform definition. There are some studies which say, 10% increment from baseline, or say 15% increment of baseline, along with some cysts and some loss of vision, or that vision has not improved more than 2 lines compared to the pre-op vision. So this macular edema definition is really important, as you can understand, but it's not, it's not well defined for this particular study. Coming to the results, how many are in each group is not provided in the results of the abstract. Straight away, they should say that, intuitively we'll feel that there are 6 groups and there are equal numbers in each groups. But as you will see in the 40 milligram group, in the 40 milligram and high dose, there are only 600 patients. Right. So then, and almost 45-46% are in the topical prednisolone acetate group. So then what made the physicians give triamcinolone in different doses, to whom? How do we know? How did they choose? And this is for a retrospective study, this is very important. How did they actually choose whom to give it and in what dose? And there is not much explanation throughout the paper that I could find. So then, that is a little bit up in arms, because it's really important, because remember, this is not a randomized trial. So then who are those 677 patients? I'll show you later on that actually they are, poor white men who are, looks like a bit experimented with. But then, how did they actually choose and how did they not is not given. And then if you think that subconjunctival triamcinolone is useful in preventing cystoid macular edema, which is something that none of us want to face, generally these are all dose dependent. So as you go with a higher dose, the risk or the odds of macular edema keep reducing. Right, so for 10 milligram, when you give it at 10 milligram per ml, if you give it at 1 milligram dose, the chance will be slightly lower. Whereas if you give a 40 milligram dose at, say 5 milligram, 40 milligram per ml at 5 milligram, then the chance of should be even lower, right? So then generally it will follow a dose dependent curve, but that is not seen here, where they say that, the high dose triamcinolone 10 milligram per ml group reached statistical significance. What about the rest? What about 40 milligram per ml group? Did that not reach statistical significance? And it'll be surprising if that did not reduce the risk of CME. And what about the 40 milligram with high dose? That should even have a lower odds ratio. But then apparently they did not reduce the risk of CME. So then why 10 milligram per ml reduces risk and 40 milligram per ml does not reduce the risk is again, a little bit, so generally this happens when the groups are not equally divided. So the 40 milligram has only 670 patients, and therefore most of the results in that group are not going to be statistically significant. So lastly, I wanted to sort of, explain how to interpret odds ratios. It's really important. So odds ratios are derived using something called logistic regression analysis, and they talk about these multivariable models and other things. So let's understand that the outcome measure here is a yes no kind of variable. That's a categorical yes no. That's CME hua ya nahi hua, yes or no. Iritis yes or no, glaucoma yes or no. And when you have that kind of an outcome, yeah, so even large Indian studies like those looking at endophthalmitis with intracameral moxifloxacin should actually have reported odds ratios, but they unfortunately don't. But then when you have very large numbers, it's good to report odds ratios. Odds ratio 1 means there is no increase or decreased odds of the event happening. Here the event is CME. Right? Odds ratio more than 1 is higher risk or higher odds, and odds ratio of less than 1 is lower odds. And it also tells you by how much. So 0.88 is actually 12% lower odds. So one, you go, in the basement, basically you're going down from 1. So you say 1 minus 0.88. So it's 12% lower odds. If it's 0.60, it's 40% lower chance. If it's 0.80, it's 20% lower chance. If it's 1.35, it's 35% higher chance, something like that. So that's how we interpret odds ratios. And this confidence interval tells us, for 95% of the patients, the odds are between 0.74 and 1.04. So that means 74 is 26% lower chance and 1.04 is 4% higher chance. Right? So when this confidence interval crosses 1, where some people have a lower chance and some people have a higher chance, that p-value will never be significant. Now, if you look at this odds ratio, risk of CME is 0.64. That is 36% lower chance of CME happening. And it varies from 57% lower chance to 3% lower chance. But the chance is always lower. This has not crossed 1. And therefore P is statistically significant. So overall, these are some of the take-home messages where we can interpret odds ratios. Lastly, I wanted to sort of show you when you compare these groups. As you will see, triamcinolone acetonide, I'll just blow it up. So this 40 milligram per ml has only 677 patients overall. And when you see these are all white, almost 85% are white. Here it is only 61% are white. So a lot of the blacks have not been given this, but there are almost all who have got triamcinolone or whites, and they are not well off. So this is median annual income, if you see in tertiles, so the highest tertile, that means the highest earning. So in this group, there are 30% who are high earners. This is 30%. Here, there is 40, almost 50% are high earners. But the 40 milligram group are not high earners, right? So they are white men who are not high earners and also are significantly more smokers. 60% smokers, whereas these are all less than 50%. They're white men who smoke and don't earn well. So I mean, so how did they actually choose whom to give and whom not to give is something which is not very clear to us, and I think that's really important and has to be given in the method section of the paper. So overall, the take-home message is, at least from the statistical angle, is how to interpret odds ratios, see whether the groups are sort of matching at baseline, and then we can draw conclusions. Here, the groups are perhaps not exactly matching, of course, in terms of numbers, and also how they are overall distributed. So I think my main contention is how did they actually choose whom to give and whom not to give when it's not a randomized study. I think it is something which is making me making it me hard to believe these results as they are given. And that's it for me. Yeah.
So Parul, we open the journal club discussion. So
yeah, I think to some of the points very correctly highlighted. Few other points are that macular edema definition has to be on OCT. You cannot just say macular edema, somebody had it, somebody not had it, and the OCT has to be done at a specific time frame. So of course there has to be a range. There will be a range. Not all patients will come on the same day of follow-up, but there has to be a range at which during, say, in the 2nd to 4th week or 3rd to 5th week or 4th to 6th weeks, that the OCT was done in all patients, and based on which macular edema was decided or not. Second most important is that there is no regimen given on the prednisolone and NSAID eye drops. How frequently were they given? For how long were they given? In what patients NSAIDs were given? Whether the NSAIDs were continued beyond the prednisolone once they were stopped or not? All of these factors will play a role in not only macular edema but also in rebound iritis, because if you continue NSAIDs longer than the steroids, chances of rebound iritis are quite less. And the duration is also important because the blood aqueous barrier takes minimum 4 to 6 weeks to stabilize. So if you have stopped prednisolone, even if you say you've given the highest and 1% prednisolone acetate, but if you stop by 2 weeks, 3 weeks, it's almost like not giving them long enough, because you need minimum 4 to 6 weeks of steroids or NSAIDs to cover the breakdown of the blood aqueous barrier where the CME can occur. So these are the basic kind of things. There was a very, very nice randomized European multi-center trial known as the pre-med trial, where they compared into all different randomized groups of dexamethasone alone, dexamethasone with NSAIDs, NSAIDs alone. And the second group was subtenon steroids alone, and third was injection Avastin alone, where they showed that the incidence of macular edema was lowest with the subtenons group, but had the highest incidence of glaucoma, with 3 patients requiring trabeculectomy. So they had 0 incidence of CME in the subtenon group. The second lowest was in a combination of dexamethasone and NSAIDs, and the highest was with dexamethasone alone when they were used post-operatively. So there is a reasonable kind of evidence that subtenons or subconjunctival depot injections can reduce macular edema, but this study is something which doesn't really bring about, to be honest, too much new information, because the design is very, very flawed.
Thank you, Shail sir. We would like to have comments from Haripriya madam now about the article.
Thank you. I think it's a very well presented. Am I audible?
yeah, very much.
Yes, ma'am.
It's a very well presented article, Girija, and I'd like to appreciate the comments from Dr. Sengupta as well. So good to go through all those basics. Now, first of all, I must credit that we learned this technique from Dr. Neil Shorstein, and we did use this in many of our patients. So I am not sure how they chose. I'm just assuming. My hypothesis was I think one is different clinicians at Kaiser use different concentrations. They don't have to all follow a protocol. That's why with the intracameral moxifloxacin study, they had a group which did not, a group which did, because it was individual physician-led decision. That may have been the reason why some used different doses, or maybe at different time points. Maybe they started off with a higher dose and then they stepped it down. I mean, all this I'm just giving as a hypothesis. And all the other points are very well said, especially the skewed data in terms of numbers and in terms of the population. The interesting thing, if you also look at the population, the highest risk was amongst the Blacks and Latin Americans, and of course the Asians. And this is true with any study we do. We find that Asians, both Indian and Chinese, are definitely at a higher risk for inflammation. So based on the discussions we had with Neil, we first did a trial. We did a randomized controlled trial where we compared two groups. The control group received pred acetate tapered over 6 weeks. And at the third week, we added also the nepafenac at the post-op day 1 for about 4 weeks. That was the control, and the study group received TA, and the concentration we had chosen was 6 milligram, and that was a dosage, and the concentration was in 20 milligram per ml. So we would get that 1 milligram of the triamcinolone, dilute it, make it 20 milligrams, so 40 becomes 20. From there, we would draw in about 0.3, and we would give that to the patient, which would make it 6 milligram. And before we started this, I actually did it on a few patients. So we started off with 4 milligram, basically. And we found that 4 milligram was safe in terms of, they again spoke about it. It's very important to have this balance, as rightly pointed in the paper, is how do we get this correct balance of the steroid dose and concentration? So it's both safe and efficacious. So from the safety point of view, 4 milligram worked well. So we had very few IOP spikes in that group, but I found that a few patients did have rebound inflammation. Again, because of the dark irises, which we see in the Indian population, and the various other aspects, including the viscoelastics we use, other aspects, our chance of inflammation in our population is higher than what you would see amongst the Caucasians. So from 4 milligram, we went ahead and tried 6 milligram, and 6 milligram was definitely more effective. And of course, there were a higher chance of IOP spikes. I had to excise the depot in 2 patients, which is not very difficult to do at all. It's just, at a topical, the depot still remains in the subconjunctival space, which you just have to excise if the IOP does not stabilize within a couple of weeks following surgery. So we then used the 6 milligram dosage for this randomized controlled trial for the study group. And we had about 202 patients in each arm. And we followed them up at 15 days, of course, day 1, 15, and 45. And tested the same parameters, rebound inflammation and macular edema. So again, OCT was very much the same, 185, 192, 185 in the study group, 192 in the control. Risk of CME, we had 1 patient in each group who had CME. Iritis was also lower in this group. And interestingly, our IOP spikes, when we did this randomized control trial, we found more number of patients in the topical group had actually IOP spikes. So we had to step down the topical steroids. So it seemed like it was a safe option from the randomized control trial. I have not yet gone to using it in routine clinical care. Of course, we had it strictly controlled as any RCT would. We did not include young patients. Again, a very nice paper by Dr. David Chang on on the patients who had highest of risk for IOP spikes. So they have an excellent paper, I think, in JCRS. Of course, in myopes, and second in patients below 40. And I'm sure we see it in our practice all the time. If you have any young myope, the combination is worse. Any young myope, you will almost always see an IOP spike. You'll have to give them some AGM. So we controlled to excluded patients with glaucoma, on family history of glaucoma, young patients, myopes. So a lot of these conditions, and of course, without any, so we did include diabetics because they part a lot of our population, they form a lot of our population, but not patients with any retinopathy. So we considered 5 years of diabetes without retinopathy. So obviously no macular edema from diabetes. And this is the result we saw. Again, visual acuity on all aspects, it seemed to perform well, and that actually got me very, excuse me, very keen to take it forward for our patients, because we know the trouble with drops, and if something works just as well as topical, of course you'll have that one patient where you'll have to control. It doesn't get controlled. The depot stays longer. So the next time I'm going to step down from 10 milligram, from 20 to 10, and then also step it down slightly to 5. That's what I'm planning to do, but that is for another thing. But these are my thoughts, which I wanted to share initially.
Thank you, ma'am. I request Dr. Haldipurkar sir to give his comments on the article and on what he feels about this before we go on to the group discussion.
Yeah, thank you, Zen. I think I like the discussion that everyone did. It's an excellent paper. I look at purely from a clinical point of view. Frankly, I haven't done any of these studies where I have used triamcinolone post-op. But when I look at this, it looks really exciting. See, I know over the years, many doctors, in isolated pockets, they have used triamcinolone intracameral at the end of the surgery, and they would, observe their patients and not put them on any drops for a long time, and they've done pretty well. But it looked very scary when you have to put in triamcinolone intracamerally. But when this study I read, and if it really works, see, I look at it like this. There are some things that are not said well. Like, for example, did they use antibiotics post-op? That is not mentioned. Or with regards to macular edema, at what stage or how many days after that surgery did these patients have? Nothing of that is mentioned. But the very fact that it's a retrospective, that means it's been going on from 2018 till 2021. That means that probably the regimen of using triamcinolone has still continued in that area, in that group of hospitals. That means it's really working. So I'm really excited about it, because all of us realize that post-op, when we have to give a lot of these medications for a month or maybe 40 days, there are lots of compliance issues, a lot of the dryness issues and all that. So if you really have a situation where you give subcunch, and then you don't have to give any of these drops and just keep them on maybe lubricants, SOS, it's, from a patient's point of view, it's really good. And what I liked here, they have done a study where they've used 40 milligram, high concentration and low concentration. I mean, low concentration, high dose. That's 10 milligram per ml, which they only use maybe low dose and sometimes high dose. And the best part was they gave it 6 to 8 millimeter away from the limbus. And that's really good, because you have it in your control. The only thing that you're really worried is the pressure goes up and the medication doesn't come down. That time it's so easy to just excise that small triamcinolone residual that's left there, which is not very difficult. And that too, it's in a very low percentage, maybe less than 1%. So considering that, I feel, what I feel is the only thing that's lacking, like Haripriya said, is this study is not done in Indian population, where probably the percentage may be slightly higher, but it doesn't really matter, because even if it's higher, if you can avoid using drops, and if this works, and maybe, of course, with an antibiotic cover for a short while, I think this is easily doable kind of a regimen we can definitely practice. But I'm sure the other experts can really add to it. I mean, after reading this study, I'm sure I'm going to try maybe 10 milligram, high, maybe let's say 4 milligram, 5 milligram I would use. And because unless you use it in your patients, in your surgeries, you wouldn't really know how effective it is. I think it's a good study. with few flaws which you always expect because it's a huge study and it's a retrospective.
Thank you, sir. So, we've heard from Haripriya Madam that she has been using Haldipurkar sir. Has I know how he likes to try new things when he hears about it. So I'm sure he'll try. We'll hear from our other panelist, Dr. Shell. So, where are you on? Like, I mean, have you tried using drop free or injecting triamcinolone alone post-op?
In fact, to be honest, I've gone on the opposite side in the last 2 3 years. I've increased the duration and I've increased the drops, particularly after I went through the pre-med study. Because in when we, there are two three I mean, and this varies from practice and institute to institute. And when you are in private practice, I would say we are doing 70% flax. I don't want even that one patient of rebound to come up 1 month later with that red eye again after stopping drops, then restart the cycle again and do everything. So in fact, after a lot of debates and thoughts, I'm using now prednisolone acetate as well as NSAID eye drops for all patients except for the obvious contraindications for NSAID eye drops. And I continue my NSAID eye drops a couple of weeks longer than when I taper off the prednisolone acetate, so that it covers up the 6 weeks periods where the macular edema can occur. And it will also cover up the very few chances of rebound that tend to occur, particularly more with prednisolone acetate, less with dexamethasone, but they do tend to occur more often than we would like to admit it. So to avoid that, I have in fact increased the number of drops and increased the duration in the last 2 3 years rather than going back.
Dr. Haripriya ma'am, I have a question. So, in your study, was the injection given in a specific location only, and any patient-related factor, means in the sense that patient, did they say that the blob of white material was seen cosmetically? Any complaints from this thing from the patients?
So actually, I injected the depot superiorly. So the reason why I chose superior is because it won't be visible, so the patient won't be concerned. And also because many of our patients, especially in the elderly, the conjunctiva is a lot loose in the inferior fornix. It seemed more, firm superior. That's the reason why I chose superior, and I went 6 millimeters. So when I started asking the surgeons, they had to go, actually scientific. They had to use a caliper, go 6 millimeter, and then I've used a 30 gauge needle so that you won't have any egress of fluid. It doesn't come back when you remove the needle. The drug won't escape. It will stay in the subconjunctival space. They have to ensure it doesn't go through and through. In terms of patient discomfort, yes, a few of them. I think some of them did recognize there was a depot. We did tell them that they are giving this medication so they don't have to use eye drops. So they did look it up. I don't think they had a lot of discomfort. So in a study, we also looked at that, in terms of irritation and discomfort, what was the score which they would give. I don't remember the exact details now, but looking at it anecdotally from seeing the patients, I don't think they complained a lot about it. There was one patient, like I said, who was not happy, and she was keen I remove it. So that was, of the two patients, one of them I had to remove because the patient was. We give the patient a kind of a small patient information sheet. So because anything we are doing new, let the patient know that this is what we are doing. So we keep them informed about this is the drug we are injecting, so you don't have to use eye drops. And if I can add regarding the post-operative regimen, so I think as Shail mentioned, NSAIDs I think are very useful in preventing or reducing rebound inflammation and for CME. We have been using NSAIDs, I think, for many years now, I think a very, very long time. However, we don't prescribe it immediately. So our regimen, we give it for 5 weeks. So I go 6, 4, 3, 2, 1. We use standalone DEXA. So our lab makes just the DEXA drops. So we use that. And our patients review at 3 weeks follow-up. And when they come at 3 weeks, we add the NSAID. Typically diclofenac, but anything could be bromfenac, could be ketorolac. Diclofenac and bromfenac do well even if you give for longer duration, but not so with ketorolac. So in case one is still prescribing Actilar or any other ketorolac, I think we'll strongly tell them to stop it within a month, not go, because you still have the chance of corneal melt with ketorolac, which you don't see much with diclofenac or with bromfenac. Thank you.
Dr. Bharucha, do you have any questions you would like to ask the panelists?
Yeah, good evening, everyone. It seems that the advantage of giving this depot steroid is to reduce or to avoid post-operative eye drops. But what about the antibiotic? Are we happy with just the intracameral intraop moxiflox, or do we have to continue antibiotic eye drops, NSAID eye drops, and lubricant? So if we are going to continue all these, then just reducing one eye drop, does it really make a big difference?
So, Haldipurkar sir, I would like to ask this to you. So, suppose you would want to give triamcinolone to be steroid free. Would you, be happy giving your intracameral antibiotic and then not giving antibiotics post-op? That would be the question.
No, I wouldn't do that. I would at least put them on antibiotics for a week, and I would give triamcinolone in the inferior fornix, maybe 8 millimeters away, and then just like anyway, I see my patients 2 weeks later, and it would be initially a very controlled kind of a thing where the patient has an easy access to me. He's from a close by area. And once I do for a month or so, maybe if I do around 100 patients, I'm really happy with that. I would certainly like to pursue that, because I exactly know, in the days, in the earlier times when we didn't give so many drops, the dryness and other issues, post-op patient complained less. But today with the too many drops, now in fact the lubricants have become a permanent thing. After the surgery, if you're putting them on other drops, maybe along with that we have to put them on lubricants. Otherwise, they always have some kind of irritation. They always come in. I really don't know if it's because we are doing too many corneal incisions. Because in the earlier days when we did scleral or scleral tunnel or conjunctival incision to do, such complaints used to be much less. But today, I'm sure, Zaid, even you would have noticed that post-op after 3 weeks, 4 weeks, patients do come with some kind of irritation and some kind of dryness. If these frequent installation of drops is the cause of it, might as well cut down all that and try it if it works. See, if it's worked for them, I'm sure it should work in Indian population as well. Unless we really try it, we wouldn't know.
Haripriya ma'am, the question to you as well. If you're giving intracameral antibiotic, could you not give it in the post-op period and just continue whatever else you're giving?
Yeah. So the patient in our populations, they do buy a bottle of antibiotic. We give them ofloxacin. They use it one day prior and on the day. So we ask them to continue the same bottle as long as the bottle lasts, typically about a week or 10 days. And that is what we did. I think we did it for about 1,100 patients, about 400 in the study, but about 1,100 patients otherwise. And for all of them, we did ask them to continue the same drop which they already had, but no other medication. Only if they came back on review and they had some discomfort, we had some lubricant. Besides that, no other medication. We didn't need to add a lot of medications actually, unless of course they had IOP spikes or some other issues.
So I think just to clarify, the intracameral moxifloxacin or anything that you use is a safeguard until the drops can take over. So the half-life or the effect of the intracameral antibiotic is going to be there for the next 4 to 8 hours. It's going to be very high, and therefore whatever that load that there is going to be taken care of. But it is not going to last you for the third day, fourth day post-operatively. And I think at least for a week, you do need topical antibiotics, particularly in the Indians scenario. So I don't think intracameral is a substitute to not using post-operative topical eye drops. It's an addition to using it.
Yeah, I just wanted to say that in the pre-med study, the arm which I remember giving subconjunctival triamcinolone, the macular edema incidence was the least out of
Zero.
all
It
the.
was zero. They had no patients of
Yeah.
macular edema.
So
Absolutely. But they had three patients whom they needed trab, and it was subtenon. So it was they had high incidence of glaucoma.
so with this dose adjustments, that could be
I'm
an
sure.
answer.
I'm sure that can be improved upon. Absolutely.
Yeah, one question. Most of our patients we do under topical anesthesia. So putting a depot preparation, would it cause some discomfort to the and spoil the surgical experience?
No, I don't think so. I mean, the patients, in fact, it was easy for me. So I was putting it in the superior conjunctival, the phonics. So I asked the patient to look down, and topical was easier. So patients were comfortable. Of course, if they had any discomfort, we'd add another drop of topical anesthetic. But I think the patients did not complain of anything. So most of our patients got the topical. Yeah.
Yeah. President sir has a question. Please,
Yeah.
Siri sir,
Have
go ahead.
anybody of us tried intracameral triamcinolone and antibiotic as a standalone treatment for this thing at the end of surgery? Intracameral triamcinolone.
Yes, the intracameral triamcinolone that has been proposed is actually not intracameral, just injecting in the AC. It's actually usually transzonular, is what they have proposed. The dropless cataract surgery that is popularly known is typically they inject the triamcinolone actually through the zonules, so it remains as a depot and not just because in the anterior chamber it will get drained through the trabecular meshwork. So even when we hear about dropless surgery and intracameral triamcinolone, it's actually the transzonular injection and not just in the AC. So I don't think there's anybody who's just injecting triamcinolone in the AC and then nothing after that.
But Dr. Shell, why are we not going towards dropless cataract surgery? I mean, why aren't we? Because I've heard a lot of speakers speak internationally, even this transzonular approach. So why is it not gaining popularity? We have seen that we with so many modifications of technique, we are not getting those very intractable kind of glaucoma. So what is stopping us from becoming dropless?
So I think two, three reasons. One is darkly, like Madam correctly pointed out, darkly pigmented iris, like in Asians and Indians, are much more prone to giving an iritis or inflammation or wound aqueous barrier leakage compared to light iridis, and therefore you sometimes observe them operate, and the next day their anterior chambers are so quiet. When you actually see them operating, you'd expect them to have a lot more inflammation next day. So that is, I think, one of the major reasons. Our race and ethnicity is something that the iris doesn't probably allow us to do that. And I think the second is, all this sounds good, giving subconjunctival subtenon, but the proper technique, proper dosing, proper preparation when that powder is made into liquid, all of these become very equally important, which not everyone is so careful in doing so many of these things as meticulously as, say, like Dr. As would happen in Arvind or other some institutes. So all of these things, factors put together, I think, are the reason. And to end up with intractable glaucoma, even one, so say 1% is 1 out of 100, which means one a month. I don't think I would accept one a month in private practice to have to either excise triamcinolone or having to treat glaucoma post cataract surgery.
I would request, Haripriya Madam and Haldipurkar sir also to just give their final comments on this, for cataract surgery for the common ophthalmologist, whether this study can, in some way benefit or, help us or kind of make us incorporate any form of this in our practice.
Well, to speak of this study, I fully agree, Dr. Shell, of what you say. Like, even to have one case of intractable glaucoma is something that you will not accept. But unless you do it in your population, you would never know. And it's an easily doable kind of a study. Let's start with a smaller dose. With smaller, see, the among the two things that really worries us is the intractable glaucoma or the rise of pressure, which doesn't really come down with one or two medication. But with regards to inflammation, you can always fall back on giving a short course of topical steroids in case your subconscious doesn't work. But if it works and if that inflammation part is taken care, I think I would be one to go for, because I know your population, your patient population, when you give them everything in detailed writing, they still make some mistake. They wouldn't put the drop. There are so many issues, a lot of contamination. Sometimes someone else has to come home to put a drop and go. So all in all, I think if you can reduce their drops, especially the steroid and antibody, it's really going to work in a long way. At least I'm going to start it from tomorrow. I would maybe start it in a very small way, but if it works, I might really take it forward.
Sir, any
Thank you,
specific
sir.
indication where you would think that they will benefit more than the normal cataract patients? Any specific, to start with, if I have to start, which cases would we select?
I would start with some of these patients for whom putting the drops is an issue. One. And number two, there are some fussy patients, who say, like, we are working and putting it like 6 times and 4 times and remembering all that. I find it as a big issue. These are the patients for whom I'll just give it, making sure that, I've taken care that, all the patients like myopes and, longer excellent, all those patients are ruled out, and then take up maybe as a pilot study and see for myself. Because unless you see it for your own self and see the comfort of doing this, you will not take it forward.
Thank you, sir.
Mm.
Haripriya, madam, your final comments.
Yeah. So just going back to your earlier question of why this was not popular, I think the trans-onlet technique is not very easy to do. There's a lot of complications also reported. Imagine putting it intravitreal through the zonules is not an easy technique. Whereas what has been proposed in this paper is subconjunctival, which is very, very doable, very easy to do. And again, we had a lot of resistance initially as well. So I know where, when we have concerns, it's obviously based on our patients. So it's difficult for us to always have that balance. Is it safe? Will it be, is there a role? But I agree with Haldipurkar sir that, compliance to medications actually is not easy. We have patients who say surgery was easy, but using these eye drops for a couple of weeks after surgery is making it so difficult for us. Especially if they are, sick, Parkinson's, they have tremors, the compliance, the mix-up with drops, the contamination. So with all of this, I think it is our responsibility to look for options. And having done it and tested it in many patients, I do think that this is a very good option for our patients. Again, not for everyone. So patients who have a high risk for glaucoma or myopes, I would not give it. Again, I think diabetics will benefit more because they, will additional steroids for those patients are always better to prevent macular edema, inflammation. So I think those populations may also benefit further from this. But I do see this as going forward. That is something which will stay. It could be any form. Need not be subconjunctival. You can have a new. I mean, there are intra. You have something in the punctum. You have different options. You have subconjunctival. You have intracameral. You have intravitreal. So there's a lot of research being done to different formulations, and we'll have to then find the thing which works best for us in our patients. Thank you.
So I think is Dr. Zain on Mr. Nikhil Masurkar is going to say something. Yeah.
So actually, NTOD has been supporting us for these journal clubs for last 3-4 years, and they've done a fantastic job for this series as well as a lot of other educational series. So big thank you to Mr. Nikhil, and being the CEO of NTOD, he just wants to spend 5 minutes talking about his journey with NTOD. So over to you, Mr. Nikhil.
Yeah, I wish you all very good evening, and thanks for having me on this webinar. So I was asked to just talk about my R&D journey. So as most of you know, the research landscape in India is always very complicated. It's a very difficult path to walk on. In our company in Endot, we started as a contract manufacturer way back in 1977. We were one of the first few to set up an eye drop manufacturing plant. My grandfather had to import machinery from Germany, train the team, and then we started with dexamethasone and a few molecules of that era. And then we moved on to having our own brands, our own R&D, our own marketing and sales. And today we're in a position where we've taken research to a whole new level, and we want to do that continuously. See, the pharma industry in India is moving from a more volume-driven, system to a more innovation-driven ecosystem. And a lot of companies in the MSME sector are now contributing towards research. And in fact, if you see a lot of the new patents filed in India, majority of them are nowadays coming from the MSME sector. So if India has to move towards right now we're a $50 billion industry, and we have to move towards a $450 billion industry by 2047, the MSME sector will really need to step up and contribute when it comes to research. So this is where we are at right now. We've taken a really bold step that we're going to go down the research route. Yes, that route is always a difficult one. We get a lot of kind of obstacles in the way. There are financial restraints. Some people don't believe what we want to do, but eventually I think that's the right way to go about it, and that's what we're doing, and we're seeing good success coming out of our research projects. It was interesting. I was just hearing a lot of you talk about post-operative treatments and about drop-free surgery and all of that. So I think one thing we're doing in that area is, compliance is a big issue. We have so many eye drops for post-operative care in glaucoma and myopia, but are patients actually complying to it? We don't really know. You all will know much better. But one thing we're doing is, firstly, we're trying to make them more acceptable by removing the preservative altogether. So more preservative-free eye drops, or using preservatives such as the ionic buffer system that we developed for the first time, and we're now incorporating it in a lot of the eye drops. So I think that's one thing we can do. The second thing we can do is to have meaningful combinations. Like, for example, we are currently working on an NSAID with a steroidal drop. So we have nepafenac, with difluprednate. So that's something that we're working on as well, so that it'll give kind of cover from both angles. We're also working on a triple combination of nepafenac, difluprednate, and moxifloxacin. The whole idea of this is that if you can combine treatments, into one eye drop, which is safe, which is effective, and yes, this will need clinical trials, and we're willing to go down that route as well. The dosage needs to be kind of titrated better, whether it's a TDS dose or a QDS dose. That's something we'll need to figure out. But this, I think, is the way forward to have more meaningful formulations, rather than just flood the market with endless number of new molecules. I don't actually believe in ophthalmology we need new molecules. We just need a better approach therapeutically, so that it's easier, and good guidelines will allow much better compliance and more better kind of efficacy as well. So that's the route that we are taking. Obviously, we are working on new things, like we've developed our insulin eye drops. We have developed losartan eye drops. In the corneal space, we are also developing a 5th generation fluoroquinolone, for the first time in the world. So all of those will come. We're also looking at a completely new molecule for myopia, called 7MX. So there's a lot of things happening in that space as well, but they will take some time, and we are committed. As a company in the MSME sector, as a medium scale company, we are we spend almost 15% of our annual profits on the R&D, which is more than double, many cases triple of what others spend. So we're taking this risk, but I think that's what gives us all the excitement and all the encouragement of what we're trying to do. Moving forward, there's also, like in the US recently, they have a
a dexamethasone kind of an intracanalicular implant for dexamethasone, which has been indicated for post-operative pain and inflammation. So those therapies also are of interest. Where potentially we can bring those into India, or we can hopefully manufacture it here at some point once that technology is there, and I'm sure it will be there. So I don't want to take too much of your time. I think a lot of discussion has happened already. But all I want to say is that, this pharmacy of the world, which we call, our pharma industry here, I think it should be the world of pharmacy. It should be everything, not just manufacturing. It should be the R&D. It should be self-reliance on APIs. And I think for all of this, I think doctors and the industry and the government institutes should work together to really kind of come out with innovative treatments which are not there in the rest of the world. But I think India can be the epicenter of research in the next 10 years. It is happening, and I'm sure it will. That's the way it's going to go. So thanks a lot for giving me this time to talk. And I really appreciate being here. And our support for such academic events will always be there. Thank you very much.
Thank you so much. So it's a time to thank everyone who has contributed not only time, their insights and valuable discussion today. So I ask Dr. Karishma Wadia to do the vote of thanks.
Thank you, sir. At the outset, I'd like to thank Enton for their constant support. Thank you, Dr. Nikhil, for sharing your journey. It was really interesting to know what actually happens from the pharma perspective. We'd like to thank our presenter, Dr. Girija, for presenting and taking up this article. I'd like to thank the moderator and the mentor, as well as all the three respected panelists. Thank you, Dr. Vaishal, for letting us be a part of this endeavor. Thank you, Dr. Parul. Thank you to our dynamic duo, Dr. Zain and Neeraj, and all the others. I would like to also thank the MOS committee, the MOS office bearers, and thank you so much to all the audience who joined for this meeting. So without much ado, we can now conclude this session. Thank you very much.
Thank you. Thank you so much. Thank you.
Thank you. Thank you.
Thank you, everyone.
Yeah. Thank you, everyone.
Thank you. Good night, everyone. Bye.
Thank you.
Thank you. Thank you.
Good night, everyone.
Thank you.
Good night.